before we welcome our guest, Dr. Tom Lee, as many of you know, we live in Rochester, New York, and as many of you know, last week revealed that an African-American man who was visiting Rochester, New York, Mr. Daniel Prude, was killed on the streets of Rochester in March. Before beginning our conversation with Tom, I'd like us just to take a moment of silence in remembrance of Mr. Daniel Prude. Thank you. With that, I would like to turn our attention to welcoming Tom Lee, who's one of the great entrepreneurs in healthcare for the last 10 to 20 years. The first healthcare app, the first publicly traded primary care network, and the future of healthcare delivery. Behind them all is our guest, Dr. Tom Lee. For his education, Tom crisscrossed the country a couple times. He studied biology at Yale, completed medical school at the University of Washington, trained in internal medicine at Brigham and Women's Hospital in Boston, and then earned his MBA from Stanford. In 1998, with two Stanford classmates, he co-founded Hippocrates and made the lives of medical students like me much better. Before Hippocrates, every doctor had a book this big. It was called the Physician's Desk Reference. Tom, I couldn't even find one. They put it out of date. After Tom, everyone had an app on their phone called Hippocrates, and they pressed the button when they wanted to know what antibiotic to prescribe for urinary tract infection or for pneumonia. On behalf of many students, residents, and physicians, I wanted to thank Tom for that great invention, but he wasn't done. He next turned his attention to primary care. In 2005, he founded One Medical Group, a San Francisco-based network of primary care clinics that offers personalized care to patients at a premium price. In January of this year, One Medical Group went public and now has a market capitalization of $3.5 billion. Not content with these two great successes, in 2018, Dr. Lee founded Galileo, which seeks to provide best-in-class care through a subscription service. We're delighted to welcome one of healthcare's most creative entrepreneurs, Dr. Tom Lee, at Chet Talks. Tom, thanks so much for joining us.
Yeah, no, thanks for having me. And apologies if my bandwidth is a little spotty, but it's as good as we can do in post-COVID world.
So let's begin with Hippocrates, a groundbreaking healthcare application that is used by 40% of American physicians, more than 1 million prescribers worldwide. What motivated you to start the company?
Yeah, I think the short story about Hippocrates, it was, three friends all interested in something entrepreneurial that was born out of a class project and ultimately led to Hippocrates. A lot of it is just a confluence of what is happening at the moment in time. But back in the day when we were in business school, the Palm Pilot was hot. And I was an avid user, but I never imagined you could use it to look up drug information. But as we started to dig into it, the realm of software programming and managing clinical content and data became apparent to us. And that was one of the core needs that we designed, with the physician in mind. Yeah.
What surprised you when you started on this effort?
Oh man, this is all ancient history. So a couple things, the vision for why I went to business school was not Hippocrates, it was actually One Medical and Galileo. So what I'm working on today was much more the inspiration. Hippocrates was just like, hey, let's learn how to start up a company, right? So it was really a startup. And for us, we were surprised at the capital appetite for startups at that time, right? So we were lucky to be starting up in the dot-com boom. So access to capital was, better than you have anticipated for a few business school students. But I think more importantly for me, just all the headwinds to starting up companies just ultimately ended up working in our favor. Back in the day, the Pocket Pharmacopoeia was the reference guide of choice. And we talked to those guys and they wouldn't license the content. They wanted to do their own Palm product. And so you know, I worked with my clinical team and we built out the content ourselves, and it ended up working in our favor because it was differentiated content. It was designed specifically for a mobile device. And so it was richer, deeper, more dynamic than, you know, a book put onto a Palm Pilot. Yeah.
What was the biggest obstacle?
Uh, it's still all product and clinical. It's like you got to get all those pieces right. You know, we take it for granted now, but you know, back in the day, if you were a med student or a physician and interested in Hippocrates, I mean, there was no real internet. I mean, there was just a primordial version of it. And so what most people had to do was buy a device, which, you know, most docs are not going to buy a Palm Pilot. They didn't have one, but they bought it for Hippocrates. Then they're going to wire it up to their computer, you know, connect it through the internet through usually a wired modem at the time when we first started. I mean, the amount of work it took to actually install this on your mobile device was extraordinary, but because the app served a need and it was designed well for clinicians in mind, I think we ended up getting a lot more uptake than we anticipated. But that's a lot harder than, in hindsight. You know, we took it for granted because we were like, hey, we didn't know any better. But back in the day, that was a pretty Herculean install process. And, you know, we tried to design it as easy as possible. But, you know, today it's just, you know, you go to the App Store and you push a button.
The app is now incredibly simple and indispensable to many and really opened the way for digital healthcare. Did you see that when you were starting the company?
Oh, I think we all saw the power of tech and data way back when. I mean, when I was at the Brigham, you know, we were one of the early hospital systems to have order entry on the computer. And I was 10x more productive than I was as a med student at the University of Washington, writing everything by hand. So to me, the power of computers and technology was pretty clear and evident. It was just a mystery to me. And so, you know, for me to go to business school at Stanford was really a focus on understanding not only entrepreneurship, but tech. Tech had to be a part of the strategy for fixing healthcare. And so to me, it was an early interest. I didn't have any background in computer software or tech, or frankly, even just general finance, but it's all learnable. I think when you go through medical training, I think you assume that it's such a niche type of area of expertise, but the building blocks are actually very fundamental. Physics, math, science all actually play a hand in allowing you to understand data architectures, software architectures a lot more readily than you would if you were just coming at it from left field. So I found my medical background was helpful in understanding kind of the principles of software design.
The lighting in your room is inconsistent. I don't know if that's because of the sun in Colorado or just...
I'm sorry, it's probably just me moving back and forth. Let me see if I
Okay.
can adjust it.
No problem. So you still practice medicine. Do you use Hippocrates?
I do. It's a little, I mean, I probably use it more than I need to, but that's just because I'm not practicing as regularly. But the pace of new medications continues to move forward relentlessly. And frankly, I mean, to be frank, I wouldn't use it if I didn't have confidence in the content. But the clinical team, the pharmacist lead, the chief pharmacist, all the kind of the key people are still involved with the content development at Hippocrates, 20 plus years later. And so, I know the quality of that team and the quality of their processes. So the content is still very valid. The software, has been a little bit languishing, but my hope is it'll get a revival soon.
After Hippocrates, you founded a network of primary care practices in San Francisco called One Medical. Why?
Yeah, so, and sorry about the lighting adjustment. This is my whole mysterious lighting effect. As I said, my primary motivation for going to business school was to, work on fixing healthcare. To me, I went into medicine hoping to help people, but the system got in the way and nobody could tell me why the system was doing what it did, right? Why were we doing these things? Why was it costing this much money? And, why were patients having such a bad medical experience? So One Medical was the first cut at trying to work on that problem. And so I knew primary care was undervalued, it was under reimbursed, and it was a core part of the healthcare ecosystem that if you wanted healthcare to work better, you needed a better, more sustainable primary care layer. And so most of my business school time and time at Hippocrates was thinking about how to build that. And after Hippocrates, having done a startup and understanding more of the tech and having enough context about what it meant to build up a healthcare company, I wanted to start working on the service problem, which is, we were one of the first tech-enabled service businesses. Back then, nobody would have funded a service business, let alone a healthcare service business, especially in primary care. It just made no sense. And so, the hybrid of tech helping services work more effectively was a novel concept, and it allows us to take different innovative companies were doing at the time. So, traditionally healthcare service companies weren't raising venture capital. They weren't building and scaling quickly. And I knew that to fix healthcare, you needed to have professional capital come in and really drive the business. And so you needed separate from a service model that would sustain that. So most of my motivation was how do I fix healthcare, and more importantly, how do you make primary care more sustainable?
How is primary care of One Medical different than what most people are experiencing?
Yeah, it's kind of what most people would imagine healthcare should look like is how I describe it. When you call, somebody answers the phone. When you book an appointment, it isn't weeks out, it's days out, same day appointments or otherwise. When people say they'll do something, they actually do it. So if they say you'll get your lab results, you'll get your lab results. If you ask them to help out with this, form or whatever, it's actually done. These are pretty low bar, kind of low bars to what people expect from healthcare. But that's because healthcare is extraordinarily complicated to manage. And if you're a primary care doc in a traditional practice, you're overwhelmed with just all the mundane tasks and the complex clinical tasks all coming through the phone or the email or otherwise. So for us, we wanted to design something that was much more normative, which is, hey, this is what healthcare should look like in primary care. The challenge was, how do you build and do that, right? It's easier said than done. And in a world that is fee-for-service predominant, high overhead predominant, it required a different mindset to building and managing a service organization that could A, perform better, but also B, generate margin to attract professional capital, and C, scale across, the US, which, there's a lot of great service businesses, across many different industries that can't scale beyond a few units. So scaling to 10, 50, 100 units is a whole different ballgame.
How did you drive high margins?
That's the kind of unknown thing, and most people kind of, even in your intro, kind of presume that it's the membership fee and it's an exclusive thing. Most people get it through their employer for free, and or the fee is so affordable that they end up saving money on their deductibles and everything else that they would have otherwise spent. So the service is actually very affordable, and that doesn't generate the margins as substantially as the cost reduction. So it's all about people, process, and technology on overhead management. The average primary care practice has 3+ staff per doctor. Their overhead is typically 60 to 70% of revenue. That's not a sustainable overhead load. And so you need to make up for it in volume, which is why the average practice is just feels like a churn mill. And no doctor wants to practice that. They just kind of have to do that to survive, given the way the economics have crept up on most private practices. So we just re-engineered the whole workflow. And it's mostly on administrative workflow, administrative overhead. But we do 10x the service at about a third of the labor cost, right? That's kind of the shorthand math of what makes One Medical work. And you don't get that for free. You get that through better hiring processes, better management processes, better technology processes, and a constant focus on improvement. So, we've been
Is
doing
that,
that
you
since
take,
day
I
one.
mean, a lot of small practices, billing or component, receptionists are a big component. Those are big labor drivers of the overhead. Are those things that you take out, or how do you manage to lower your overhead or fixed costs?
It's a whole variety of mechanisms, but the easiest way to describe it is most practices are managed because some consultant tells them to manage it, which is to protect the doctor's time and leverage the doctor's time. So what does that mean? That means you got a lot of people doing a lot of things that a doctor could do, but because they're trying to maximize the doctor's time, you got all these people. There's diminishing returns on that, though, and nobody runs the math on it. So if you've got a medical assistant who's in charge of taking vital signs and weighing a person every time, by the way, and the doctor doesn't need a blood pressure or a weight every single time, and if the blood pressure is off, they're going to check it anyway because they want to make sure that it's high or not, then you're actually just paying for somebody who's doing redundant work. So there are a lot of people in the process that are doing assembly line work where they should be doing job shop work. And so it's just an operational reconfiguration. Run the practice model much more like a job shop than an assembly line. And that's why people feel like, separate from the operational efficiency of running it like a job shop, there is the experience of what a job shop feels like. An experience is, the administrative assistant greets you, you have a seat, the doctor comes gets you, you're chatting with the doctor. You're talking to two operators, the receptionist and the physician. There's nobody else in between. There's no check-in person, there's no check-out person, there's no weighing me person, there's no interviewing person, and then the doctor, right? It's just the greeter and the doctor, or the physician, or the clinician. Yeah.
Some of I see all my patients over the internet, and we actually have a very, very similar model. There's a research assistant who makes the connection, and then it's me. You talked a little bit about the cost structure. Can you talk a little bit about the payment model for One Medical? How's that different than a typical primary care practice?
It's more radical than people realize. So when we started, we wanted to build the model on value, right? So, but the market wasn't paying on value. This is pre-Affordable Care Act, and even post-Affordable Care Act, very little of the market is actually fundamentally paying on value. But pre-Affordable Care Act, we knew we wanted to do a value-oriented model that would improve quality outcomes and lower total cost of care, but on a fee-for-service world. And people say, you can't bridge both. And I'm like, that's hogwash. You can do both. But it requires a mindset to execute on an operating model that's consistent with value, but funded by fee for service. And so the way you make that work is you reduce your overhead. And that's what we did. And then you reapply that overhead to value-oriented initiatives, such as virtual visits, virtual care, all the things that weren't happening in traditional practices we were doing, since the dark ages, even though we weren't getting quote unquote reimbursed for it. And so a lot of our savings were reinvested in value-oriented processes, protocols, virtual services that have propagated even beyond to today. And then as the contracts migrate more towards value, we've been able to, absorb more of those contracts on risk. But we're not dependent on a risk-based architecture at One Medical, but we're fully capable. In fact, there's some recent studies that shown for employers, the cost savings is pretty significant. And we designed it that way from day one. So how we operate, how we hire, how we refer, all of that is managed as a cohesive stack built around value, even though technically, we're not being reimbursed for it.
One of your largest investors and customers is Google, which uses One Medical for its own employees. Who are your typical patients or customers at One Medical?
It's a pretty broad spectrum. I mean, if you think about early innovators that wanted One Medical, that was kind of the target segment, right? To challenge ourselves with the most demanding customers and clients allowed us to then offer the same level of service to anybody else. And so no matter if you're at Google or, a small mom and pop shop or, some large retailer, we service all of our patients equally and with the same level of service and execution. So the fact that we have a lot of notable clients is great. It's good validation, but it doesn't change the nature of what people are being offered. So it's a pretty broad spectrum of clientele from kids. We take care of prenatal patients, in terms of prenatal care. We do pediatric care, we do adolescent care, adult care, we do senior care, we take Medicare. I think the only one we don't do is Medicaid at this stage, but that's obviously why, I wanted to start focusing on Galileo, which is really designed around broader populations. But for the average person who needs medical care through a high quality primary care office and virtual service, One Medical is a fantastic solution.
COVID-19 has highlighted a lot of enormous disparities in health in the United States. African Americans, for example, are 2.5 times more likely to die from COVID than white Americans. Do companies like One Medical address or exacerbate disparities in care?
Let's kind of maybe separate the two out. Disparities in care are a fundamental societal problem that's, decades, if not more, in the making, right? So that's a fundamental solution that we're going to need to solve for from a societal perspective, and it's broader than obviously just healthcare. Within the context of One Medical, we're offering access to anybody at the same price point, if not affordably, across broad spectrums of communities that we're in. So we're reflective of the nature of the communities that we're in, both on the provider side and on the patient and clientele side. So I wouldn't say we're increasing, if anything, we're decreasing disparities because we're improving access, but it's less about disproportionate access. We're just giving more people more access to better healthcare. And so in our minds, that's a plus compared to the average medical practice where it's weeks to get in to see anybody. So I think everybody's hampered by the medical system's access in general, but I think we are improving that broadly. Obviously with Galileo, it's a broader arc of what we're focusing on, but the focus is less necessary. It's certainly impacting different ethnicities and backgrounds disproportionately because of our focus on Medicaid and Medicare. But if you go to most clinicians, the goal and intent is to take care of everybody thoughtfully and accessibly. But the challenge is broader than that. It's the system and the access to the systems that creates the disparities, separate from the environment and, obviously some inherent biases.
As a reminder to our listeners, we're going to take your questions for Dr. Lee in a few minutes, but please have your questions ready and put them into the chat or into the Q&A. You mentioned Galileo. What made you decide to transition from One Medical to Galileo?
Yeah, I think obviously for me, the motivation to be in healthcare as an entrepreneur is to solve the bigger problem, which is how do you make healthcare higher quality and affordable to everybody? And so, well, One Medical was a great first cut at building a next-gen primary care platform that can scale, and I think hopefully people would agree that we validated that model and continue to scale that. There's still a broader question for me, which is how do you take care of the most vulnerable and underserved populations in the community? So I wanted to, leverage my expertise and, not distract from the core One Medical focus, which is, obviously what it's been doing for the last 10 plus years, and start to re-examine and rethink a model for a broader, more complex population. With a deeper tech stack and deeper tech investment. So, when we first started One Medical, it was pre-iPhone. The modern platform was Ruby on Rails. The whole tech stack was very different, and the tech stack today is obviously very different. And I think there's different folks that can succeed at transforming healthcare And, a lot of those folks are what I call tech first people. And there's nothing wrong with that. We grew up in a Silicon Valley world where there's a lot of tech first people. And the challenge a little bit is if you lose the clinical lens and the humanity lens to that, it's not the vision that I would want to see for the future of medicine. So I wanted to have a patient and clinician oriented model that leverages tech across broader populations and ecosystems. And to me, like, the only way to do that is to start from a clean slate and build a new architecture.
How is Galileo like One Medical? Different?
I almost designed it separate from, One Medical is down the fairway. It's a great model of care for the vast majority of folks that want an office-based experience tethered to a digital experience. So it's a fantastic model. Galileo is just different. The way we think about it is we're looking at broader constituents, right? So we're looking at people with Medicaid, Medicare, a really broad range of complex and social issues that go well beyond what One Medical is designed for. And then we're also looking at clinical decision making and how do you improve the effectiveness, the efficiency, and the outputs of clinical decision making. So it's a more radical cut at the clinical care model. And so we're kind of re-examining almost everything about the clinical care model. One Medical was, it was a first pass cut at redesigning a primary care model. Galileo is just re-examining the whole clinical care model across broad populations.
One Medical seems to be focused on primary care. Galileo seems to be addressing virtually any specialties. Is that correct?
It's kind of transcending these kind of historical notions of specialty and migrating to a more universal set of answers, right? Independent of specialty.
And then who are your customers and what's your reach?
It's complicated. So we service a whole range of customers, right? By design, it's the antithesis of what most people say you should do in a business, right? Be very narrow, be very focused, and get your product market fit on one segment, and then drive the hell out of it. We've got a pretty broad swath here, and part of it is, as clinicians, we've cared for a whole range of patients across, the spectrum. So lower income, higher income, rural, urban, commercial Medicare, Medicaid, uninsured, exchange. So we've seen these patients clinically, and we now have the operational and technical ability to service them. So you name any cohort and we can probably service them through different types of contracts and relationships. So briefly, if you wanted to experience the digital service, you can go online and just install the app and start getting instant digital care. Right now it's, anywhere from $9 to $15 a month, but it's all you can eat, very affordable medical care. And we're available in 10 states right now, direct to consumer, and we're currently contracted with 30 plus employers in 30 plus states at this stage. So we're pretty rapidly partnering with employers and payers. And then on the Medicare and Medicaid side, we're broadly partnered in some key core pilot programs. And so those are test programs that are much more intense value-based programs. And once we have a few more data points on that, we'll start to scale and commercialize what we call the high intensity care model side.
And so what are your aspirations for Galileo?
It's the same thing as to why I went to business school, which is, to start improving healthcare quality and affordability. So this is hopefully the next phase of that. But we'll see. So far, so good.
We'll turn to some questions. Polga Teskin from London said you've increased access to primary care by reducing wait times. Why do you think an average primary care physician cannot practice the way you do? or more broadly, what challenge should they overcome to achieve the same access you offer?
Yeah, it's a great question. It's funny. It seems like a mystery, but it's also so basic when you hear kind of the thought process. But it's all about management and intention. The concept of open access has been around for 30 plus years, right? And it's a simple, very physical inventory type of thing, right? Meaning a physician or a clinician can only see so many patients a day. There's an expected demand per day. And if demand exceeds supply, you'll start to build an inventory. And at some point, that means that a same day appointment when you're first starting up your practice becomes a same week appointment 1 year into practice, which becomes a 1 month wait list over time. And typically what happens, my thesis on why most practices have a huge, what I call inventory of appointments needed to be booked, is they don't staff vacations as aggressively when they're on vacation. And so every year that you take a 1 to 2 week vacation and you're not seeing patients, you don't work doubly hard when you come back from vacation. And so you've created a 1 to 2 week queue at scale. And then over time that just accumulates. And then there's an attrition rate where people's tolerance for wait lists go up to 3 to 4 weeks. They're like, I'm going to try to find somebody else. So it's a universal phenomenon that is readily managed by just having the discipline of managing capacity and having some reliability of substitutes. That's the only other kind of nuance to this, because most practices are managing physicians as individual operators. And so what does that mean? It's kind of like the hairdresser at a salon. That hairdresser is really good at coloring and styling, and this one's really good at men's cuts and whatever. And so there's no substitutability. So when your hairdresser is out, you're not going to go see some other hairdresser. You're going to see your hairdresser when he or she is back off of vacation. And so physicians are managing their practices like that. So there's little substitutability, whereas we as a group at One Medical wanted to have a consistent care philosophy, wanted to have a consistent level of service, wanted to have a consistent level of patient interaction design, so that when you saw the on-call doc that happened to be covering your primary care doc when he was on vacation, it has the similar feel that you're willing to substitute that other physician or clinician, right? So that's kind of the short story.
Last week, Dr. Trent Haywood was very bullish on the future of telemedicine. You appear to be less so. Can you tell us a little bit about why?
I mean, it's shades of gray here, so I don't want to make it into some polarizing debate here, but we've been doing video visits since over 10 years ago. So obviously we're bullish on video visits and telehealth in general. And sure, the market is facilitating a surge, but let's be honest here. It's because of the lack of substitutes, and over time, when those substitutes return, I'm not sure the demand is necessarily going to be the same. So we're in a hype cycle right now in video visits, and that's great for the market caps of televideo companies and telehealth companies. But in reality, it depends on what you mean by telehealth, and it depends on what you mean by transformation of healthcare and what this really means for the future of healthcare. So will video visits go up as a proportionate share? Yeah, that's true. And is it being catalyzed by COVID and some of the reimbursement philosophies? For sure. Does it change the fundamental nature of quality and cost in healthcare? I think that's still to be seen. So it's like saying, to me, it's not as exciting. Like, even if it is true, if it doesn't change the quality or cost of healthcare, it's just a different distribution mechanism to the same problem. And so to me, it's interesting, but not exciting. And then there's a separate issue, which is if you're replacing reimbursement on an office visit on par with video visits, but you're not proving that either cost of care is improved or quality of care is improved, and perhaps you're actually adding units of care over time to the population without impacting the outcomes, that's hyperinflationary, right? And so that isn't helping the problem, that's actually hurting the problem. So it's a short-term windfall for video vendors if you can charge on at parity for an office visit. But my concern is that the math needs to pencil out at the long run. So I think there's still a lot to be solved and understood before we get too excited about this never going back to the old world thing.
At One Medical or Galileo, do video visits end up increasing utilization? Do they have any impact on quality of care?
Yeah, I mean, obviously, One Medical, it's an omni-channel strategy. So we've shifted to video visits, and the team's done a fantastic job at managing that. So we have the capability and capacity to switch virtual and office and back and forth. And so there will be some structural change in terms of patient expectations and the operational capabilities. With Galileo, we're digital first. So by definition, everything that we're doing is digital, including video. So for us, yeah, it's been obviously positive in terms of traction, interest, engagement. So, we're part of that wave as well.
What else does the future of healthcare practice or healthcare delivery hold?
I think we have to, if you had said, hey, pre-COVID, we were in this interesting era of transformation. Post-COVID, it's more radical and accelerated, and could, more people can get hurt from it. So I think, I can't tell if this is going to be a catalyzing force or a destructive force just yet. It's still a TBD on healthcare delivery. So separate from the short-term, what I call choppiness and rockiness of what it means to be a clinician or a physician in the American healthcare system today, long run, meaning let's call it 5+ years, I think, the practice model starts to revive again, and we start to see what I think can be a re-examination of what it means to be a clinician, and allow for much more effective care and the use of technology within that care. But I still think it's, realistically 5 years out plus. But obviously we're working on it, and we think that we've got a model that represents some version of that future. But yeah.
Before I get to my last question, what are we not talking about? What are we overlooking?
I don't know. To tell you the truth, a lot of stuff that we're talking about in healthcare and healthcare policy worlds is so far removed from the individual patient and their day-to-day needs that, to me, I think having a greater appreciation for what's really going on in the field, where clinicians and patients are truly interacting, right? We're at an abstraction layer that's so far removed from what's going on day to day. And, certainly as we've been building out the Galileo model, and we're doing a lot of home-based care and intensive care for complex populations, there is a lot of, there is a lot of flaws to our healthcare problem, separate from, what we've been talking about, the abstract. And so hopefully we can, better address the needs of those individuals, because it's hard. These are really hard problems to solve for. And I think, credit goes to the healthcare providers that are on the front lines every day. And that's broadly, that's not just physician or clinician. It's broadly, people that go to homes, whether they be, nurses, caregivers, and hospice folks. I mean, there is a lot of stuff that's going on out in the field. And I think, it's hard to, it's good to remember that there's a lot of great people that's doing great work despite the healthcare system being in the way.
So here we just got a question from Prina Mintz, who says, for complex patients, quality outcome coordination of care with expanded clinical teams is essential. How does Galileo solve for that?
Yeah, that's part of our thesis on Galileo is we're moving away from the physician only model or the physician centric model to a multidisciplinary team that's medical, behavioral, and social across a broad range of populations. So it's interdisciplinary by design, but it's trying to build a cohesive process in DNA architecture that incorporates everything so that it can behave smoothly, right? Because the challenge of coordination energy is, or the challenge of all the interdisciplinary folks is the coordination energy. So a lot of what we're trying to do is coordinate that energy effectively, so it's effective. But by design, you know, I think care in the modern world has to be interdisciplinary.
Krista Droback from the Alliance for Connected Care asks, how much are you thinking about policy barriers like the definitions of asynchronous care at the state level or cross-state licensure portability?
Yeah, that's the challenge. A lot of, you know, these concepts are, you know, a little bit foreign at the legislative level, and we don't even know for sure what the economics are like at scale because it's going to vary by population. And so I get nervous about solving all of these technology barriers with reimbursement codes. Obviously, the cross licensing is a unnecessary friction. So, you know, the more that can reduce the cross-state licensure issues, the better. But separate from that, the reimbursement on what you're paying for what service for whom, you know, async, sync, you know, chat, email, to me, I get nervous about micro slicing these into codes and doing these a la carte. So I think, you know, we'd be better off looking at more bundled digital service payments of some sort. That's my personal bias. Yeah.
And in state licensure, some states in the setting of COVID have waived licensure requirements for a state. Do you see state licensure going back to what it was pre-COVID, or do you see any changes occurring in Medicare or other?
I don't know, you know, so much of it is local, right? It's protectionist kind of folks in their local ecosystems, and, you know, it's coming at a place of either fear or territoriality, or, you know, it's a political game, right, at the end of the day. So to me, it's really hard to predict politics and how that should happen. So I think, you know, the real question is there some federal authority that can supersede that? I don't know, but that would probably be the way to start to solve some of those problems. But, you know, that's a whole separate issue about federalism, but I don't know how the state boards are actually regulated. So that's beyond my pay grade.
So in addition to Tom Lee, we have two other great speakers on Chet Talks this week. This week is our NIH-funded Future of Parkinson's Clinical Trial Symposium. On Thursday, September 10th at 3:30 Eastern Time, we'll speak with Ann Wojcicki, the CEO of 23andMe. And then on Friday, September 11th at 2 p.m. Eastern, we'll speak with Mr. Bakul Patel, the Director of the Division of Digital Health at the FDA. If you want to know how companies and regulators are shaping clinical trials, join us Thursday at 3:30 to hear from Ann Wojcicki, and Friday at 2 to hear from Mr. Bakul Patel. So Tom, on your LinkedIn profile, you say you're a man of mystery. You refer to mystery in your lighting. What is the mystery?
Oh, it's just a joke. Yeah. I put it on there when I was first signing up for LinkedIn, and I haven't changed it, but people find it intriguing, so I've kept it there. So that's it. There is no, it's kind of like there is no secret ingredient, you know, it's like, sorry. Yeah, no, it's just, I was screwing around with my title because I'm not big into titles, you may or may not know. And so I thought that would be funny way back in the day when LinkedIn was just getting up and running. I just haven't bothered changing it. Yeah.
Well, Tom, man of mystery, many thanks for joining us on Chet Talks. I greatly appreciate it. And we're looking forward to all the future disruption that you bring to healthcare. Until Thursday, we thank you from the Center for Health and Technology for joining us, and we look forward to discussing the future of Parkinson's clinical trials with you later this week. Thanks again, Tom.
Thank you. Take care.